I realized a little while ago that I'm in trouble because I'm not listening to my father. I tried to talk Jerry Sanacora, my partner in the interventional psychiatry service, into going next because my dad told me over and over again, never follow a class act. So Jerry said no, so I'm stuck with this awkward position. Trying to figure. I just clicked my name, right? Okay, I'm going to talk about neurostimulation, mostly about ECT. This is a clinical talk. I'm not going to show a lot of research slides, but I want to give you a sense of where we've been and where we're going. Things are changing. This is a 18th century Italian philosopher who says, slumber in the tents of your father. Slumber not in the tents of your fathers. The world is advancing, advance with it. If I weren't trying to be so formal, I would have used Bob Dylan's line that the times are changing. Things are getting different. I cannot give a talk without having at least one or two slides from Gary Larson. This says, Professor Lindquist in a seminar on compulsive thinkers illustrates his brain stapling technique. So there are other controversial treatments in psychiatry other than just ECT. You've heard all morning, I'm going to try not to repeat too much, but it may be worth repeating that there are almost 20 million people in any given year, adults in America, who are stricken with major depression, that suicides eclipse homicides in the U.S. annually by 1/3, and the elderly are particularly at risk, as are adolescents. An important figure to think about apropos of cancer, and I'll talk more about this, is that the death rate from depression related to suicides in America is the same as the death rate for breast cancer. And you can't hear that too much when you think about how we undertreat these illnesses and don't think about treating them adequately. Medications and psychotherapy often fail, leaving a large percentage of those slightly less than 20 million people without effective treatments. They particularly fail with people who have illnesses that are complicated by catatonia or by psychosis. And we know that antidepressants, at least in some populations, and we can't really predict this very well, may increase the risk for suicide, particularly if they're used inappropriately with people with mood lability. Just to further illustrate this, the STAR-D study, which was a sequence treatment for depression, shows that we're really, the more treatments you fail, the less likely you are to respond to treatment, is the way to look at this slide. And three or more treatment failures, your chances of responding to another treatment, another medication treatment, are about 7%. In the interest of time, I think I'm not going to repeat that. So why do we think about brain stimulation for depression? One thing that happens is there's medication under treatment. We don't have a truly shared definition of what treatment resistance is when we talk about treatment-resistant depression. People who work with me know I hate that term because it implies the patients are resistant rather than that we have inadequate treatment for them. But we have about 1/3 of our patients go on to 3 or 4 medication trials before they have anything resembling a reasonable response, and some never have a reasonable response. So much, right? I always feel like I need a 10-year-old when I'm doing slides or using a computer. Although I think I get into trouble when I say that too loudly. A lot of side effects from medication. Many people can't tolerate medications. If we go back to the earlier talk on genetics, we do not have good genetic predictors of what antidepressants people will respond to. It tells us very little about response, actually nothing about response to treatment, and maybe something about the increased risk for side effects. We all know about things like sexual dysfunction, but weight gain is a problem, fatigue. We see patients who are chronically exhausted from their medications. Psychotherapy, particularly the kinds that have been demonstrated to work, cognitive behavioral therapy, are hard to access. that we've had. Dr. Wilkinson has done some striking early work showing that our patients improve if they can have cognitive behavioral therapy along with the interventional treatments, do better than with the interventional treatments alone, but it's hard to access it and there's limited insurance coverage for it. So the underlying premise of when we talk about neuromodulation or electricity is that the brain is an electrochemical organ, that it's both a organ that communicates along the central nervous system with chemicals, but also with electrical energy, that this can be modulated by pharmacotherapy, but also device-based electrical approaches seem to modify this communication in a way that's at least salutary, if not therapeutic. And there's been an explosion of interest in this in the last 20 years, and that there are ways of electrically stimulating the brain that may help alleviate suffering and also induce remission. And these tools are actually changing the way, you've seen in the earlier talks, Dr. Corlett's talk, that these tools are changing neuroscience research, and they're letting us actually look at the central nervous system of living people and make changes in ways that are at least therapeutic but not harmful. Whenever I'm asked about why psychiatry is so far behind other branches of medicine and we don't have the same kind of empirical knowledge base, for years I've been saying it's because we can't biopsy the brain the way we can biopsy the liver or the heart, and we're finally getting the technology available that we can actually look at what's going on in a living human brain and make interventions and see how those interventions are effective. So again, if you look at this slide, there's all of this chemical stuff that goes on, and we've been spending a lot of time and a lot of research looking at how our drugs interact with the synapse and improve synaptic transmission, improve growth. But the whole point of all this chemical activity is to send an electrical impulse. So the brain is really an electrochemical organ, and we're starting to pay attention to the electrical part of it. So what are the brain stimulation techniques? I'm going to focus on two, electroconvulsive therapy, because it's something I actually know something about, and transcranial magnetic stimulation, which is something I'm learning about. The FDA-approved treatments now for the treatment of depression are ECT, electroconvulsive therapy, in particular a modification of ECT called ultra-brief pulse width ECT, which I'll talk some about in a few minutes. And transcranial magnetic stimulation is approved specifically for the treatment of depression. I think there was a question earlier about insurance coverage. In Connecticut, these two treatments that are approved, we don't have difficulty getting insurance to approve these treatments. Vagal nerve stimulation, where an electrical magnet is implanted in the chest and transmits electricity to the vagus nerve, was approved for depression, but we've never been able to get adequate coverage for it, and it's a controversial treatment, and the data for its efficacy is at best mixed. People may hear about it because it's also used to treat refractory epilepsy, and it's still being used for that. FEAST, focally electrically administered seizure therapy, is a modification of traditional ECT because a seizure is still induced in FEAST, but it's induced in a way with a very narrow current that seems to reduce cognitive side effects, and that may get approval soon. There's another treatment that's left off this slide, which is MST, magnetic stimulation therapy, which is a modification of TMS, where instead of using electrical energy, it uses magnetic energy to induce a seizure, and that there's also a lot of interest in study of that. Neither of those treatments have been approved. Deep brain stimulation, here at Yale, there's a project underway to start using deep brain stimulation where electrodes are implanted in the brain attached to a magnet that stimulates the brain directly. And the best data to date is not for depression, but for refractory obsessive compulsive disorder. One of the difficulties, I'm going to move on to give you a turbocharged overview of ECT and an even faster overview of TMS. But Governor Dukakis asked me how I got into EC to begin with. I forgot to tell him that I was a psychoanalyst, so of course I got interested in ECT early on. When I was early in my training, there was a catatonic patient who everybody agreed needed ECT, so my attending told me to go into this room down the hall and administer ECT to the patient, and I said, I've never done it, are you coming with me? And he said, no, the nurse will show you how to do it. So when I became an attending, I thought, if we're going to do this treatment and we actually think it works, maybe I ought to learn something about it. So I went away and took a course for a couple weeks and decided to learn something about it. And the next thing I knew, I'd become an expert in ECT. But that says something about the attitude towards this treatment, and the stigma of this treatment is pervasive. If I were a sociologist, I would look at the public attitudes about ECT as an example of how we think of psychiatric illness as not being real, as being the patient's fault, as not having the same valence as physical illness, is something we don't need to treat effectively. If you want to think about how things have progressed in the 30 years since my first experience, the American College of Graduate Medical Education that sets the standard for psychiatric residents training has one sentence about ECT. It says that the resident should be exposed to it. I think they confused it with the Zika virus, but I'm not sure. And what we've done at Yale now is we now require our residents to become competent in administering ECT, because if you go back to Dr. Crystal's slides about how underutilized this effective treatment is, part of the problem is the public perception of the treatment, but the other part of the problem is we have bought into it the same way the general public has bought into it as a psychiatric profession, that we're not training our psychiatrists to do it. And as my colleague Jerry Sanacora always says, that psychiatry is one of the few specialties where people feel free to do what they like to do rather than what the patients need. And to echo Mrs. Dukakis' statement, we need psychiatrists not just to stick to their patients, but to learn how to treat the patient with what they need, not what the individual doctors want to do. So I'm often asked to talk publicly, to be interviewed for stories about ECT, and this is a illustration from a magazine that Dr. Crystal has already talked about, but it's also reproduced over and over again. This was in a magazine article where the reporter told me they wanted to do a serious, non-biased story about ECT, and this is how they illustrated it. So as a recovering analyst, I like the Rorschach test, and when I talk about ECT, I usually want to do a word association, and I say the word ECT and ask people what they think of first, and there are usually two responses. In the room, people say they thought of One Flew Over the Cuckoo's Nest, or they lie. Does anybody know what Jack Nicholson, you can't answer this, my residents are not allowed to answer this. What did Jack Nicholson say about ECT and One Flew Over the Cuckoo's Nest 45 years ago? No takers. He said, boys, I've been electrified. The next woman I get it on with is going to light up like a pinball machine and pay out silver dollars. Our marketing people declined to put that in our brochure. But nowhere do you see such a discrepancy between effective treatments, an effective treatment in medicine and the public perception of it. And I would contend that people have lost their lives because of this, and that although it's amusing at times, I end my rounds in the morning every day after we've reviewed the patients by saying, now let's go out and cure mental illness. People kind of snicker, but I think we need to understand these are illnesses that we're treating. They're serious, they kill people, and we need to treat them effectively. So electroconvulsive therapy has been around for a while. So we've known that electricity can reduce symptoms in people with psychiatric and neurological disorders for many years. Hippocrates wrote that he saw patients with insanity had reduced symptoms after they were suffering convulsions brought on by malaria. There's an account in AD 47 of a physician using an electric eel to cure the headaches of Roman Emperor Claudius. A Jesuit missionary in the 1500s wrote of the Ethiopians using electricity to expel devils. Paracelsus, a Swiss physician, used camphor to produce seizures to cure insanity. In the 1700s, individuals treated with hellebore, beautiful flowers right now, by the way, went into convulsions and coma, and they were cured of mania, or what they called raving madness. And in 1792, John Birch used electrical shocks to the head of patients in order to cure them. In the 1800s, there have been reports of insanity being used to being cured with electric shock. Insulin coma therapy was invented by Sackel. It involved giving insulin to cause hypoglycemia and a resulting convulsion. And actually, for people who have seen A Beautiful Mind or read about John Nash, he did not receive ECT. He received insulin coma therapy back in the 30s. And Meduna used camphor to treat schizophrenia, or what they were calling schizophrenia. We know from the earlier talks that what we're calling illnesses may not really imply what the biology of those illnesses are. Later he used metrazole. Since it induced a seizure faster, they knew that inducing a seizure was what was therapeutic. ECT has a scientific background. If you go back into the history of ECT, in 1937 there were two neurologists who were studying epilepsy, Serletti and Bini. Serletti was interested in finding an animal model for epilepsy that he could reproduce in a laboratory setting in order to study the effect of seizures. He realized that in the slaughterhouses, they were applying an electrical apparatus to the head of animals, and they would fall down, shake, and then pass out, and then they would slaughter them. It was known as a benign way of terminating animals that were going to the slaughterhouse. He realized that what was happening there was that they were using electricity to induce a grand mal seizure, and he modified that apparatus so he could use it in a laboratory. He first used it in a laboratory with animals, and then treated the first patient in a railroad station, probably who was catatonic. And in 1938, he reported the first use of electroconvulsive therapy treatment in what he called a man with schizophrenia. But if you read the clinical description, it was clearly someone found in this train station in a catatonic state. First electroconvulsive therapy treatment was given in the United States in 1940. So we're talking about a treatment that's been in use for the last 76 years. One of the things that's always striking to me is the notion that a movie that depicted a treatment 45 years ago is an accurate depiction of what we're doing today, and nothing could be further from the truth. 30 years ago, when I did cholecystectomies as a surgical intern, they took 4 or 5 hours. The patient stayed in the hospital a week. We don't think that we're doing surgery that way now. I went as an outpatient, had my gallbladder taken out, and was home in a couple of hours. So things do change in medicine, including ECT. So there have been major advances since 1938. We're not operating with the operating windows opened anymore for ventilation. We understand more about what's therapeutic about ECT. Modern anesthesia has been used for over 50 years. People are anesthetized before they receive ECT, and we use neuromuscular blocking agents. So if you watched a treatment, what you might see is slight toe movements. We started to understand that the way we administer energy, and this is one of the things that's still very much a field for research. The way we administer the energy, the shape of the wave that we're using makes a difference in terms of therapeutic response and side effects. And so we now use something called a pulse wave machine, where the electrical current is delivered as a pulse, as opposed to 35 years ago where we were using a sine wave machine. What this allows us to do is much more carefully titrate the dose of electrical energy that we're using in order to induce a therapeutic seizure. There have been major advances in where we initiate the seizure from in the brain, that we don't do it the way we were doing it even 30 years ago. It's changed a lot in the last 10 years. So there are advances in where the leads are placed, and that reduces side effects, increases efficacy. And there's been a shift to what we call right lateral lead placement, where the leads are placed only on the right side of the head as opposed to bilateral treatments. We now understand that the way the morphology of the seizure appears on an EEG strip that we monitor during the treatment is related to the efficacy, the therapeutic efficacy of that treatment, and we pay a lot of attention to the shape of the EEG. Up until 20 years ago, you could still buy a machine without the capacity to monitor EEGs. Those are no longer on the market. And finally, we have an increased focus on the variables of the pulse wave and how wide the pulse is and how many pulses we give per second, and that also contributes to side effects and to efficacy. And it also is the basis for the development of some of the newer treatments, in particular the FEAST treatment that I talked about earlier. One of the major differences in that treatment is going to be the width of the pulse. Many disorders respond to ECT treatment, primarily mood disorders, but both major depression without psychotic features, with psychotic features, bipolar depression. What's interesting is bipolar mania responds to ECT, so we have a treatment that's effective for both. Fortunately, for the vast majority of patients with bipolar disorder, our drugs work significantly better for mania than they do for depression, so it's rare that we have to treat a treatment-resistant manic patient. We're increasingly using this to treat certain kinds of schizophrenia, particularly people with refractory psychosis on Clozaril. Clozaril is a powerful antipsychotic medication, and the combination of ECT plus Clozaril seems to be more effective than just using Clozaril alone. So we're seeing an increasing number of patients either with refractory psychotic symptoms or partial response to Clozaril. One of the interesting things about ECT, and this is where I think the stigma comes in because it is not well studied, there have been repeated placebo-controlled studies showing that it improves the movement disorder in Parkinson's disease. And there are some very nice studies looking at Parkinson's, in particular Parkinson's without depression, because one of the symptoms of depression is psychomotor retardation, and you see motor problems with people with severe depression. It's important to look at Parkinson's without that, and there have been placebo-controlled trials, comparative trials showing that it works effectively for Parkinson's without the concomitant depression. So what happens with ECT? It's a very mysterious treatment. The patients come in, it's a minor surgical treatment. The remarks about the dentist that John made earlier are interesting because we treated a dentist a few years ago, and I told him I was telling my patients that this treatment is like going to the dentist, and he said, "Oh no, it's nothing like going to the dentist, it doesn't hurt." So I stopped telling people it's like going to the dentist. Anesthesia is administered, the patient's put to sleep, so it's like a minor outpatient surgical procedure. At Yale, about 95% of our patients come from home, so it's really an outpatient treatment. Once the patient is asleep and they're paralyzed with a neuromuscular blocker, we administer an electrical stimulation. That electrical stimulation has a central effect on the brain of causing a vagal discharge. So you can see a dramatic slowing of the heart rate. then a grand mal convulsion, then another vagal discharge, and sometimes a slowing of the heart rate again, a fall in blood pressure, and then a rebound rise in blood pressure. And the things that we worry about with ECT in terms of side effects are really related to the effect of inducing a seizure, rapid changes in heart rate, rapid fall in blood pressure. I say this in the context of there's no one medical condition that would contraindicate ECT. So we have treated many patients with pacemakers, defibrillators, histories of MI successfully without any deleterious side effects. It just means we need to be even more careful than usual. So ECT is a safe, very effective treatment for depressive disorders. It's either, it's an effective first-line treatment. We rarely use it first-line. We use it usually after multiple antidepressant failures. Between 80 and 90% of patients will respond to ECT. So it's the most effective, fast-acting treatment for urgent care, best response for patients who are severely depressed, works in 10 to 14 days as opposed to medications which can take up to a month or a month and a half. It is the treatment of choice for catatonia. We have one other thing we try with patients in catatonic states, and that's Ativan. If that doesn't work, we quickly proceed to ECT. The story about ECT and catatonia that our NAMI representative told this morning is powerful. We treat 4 or 5 catatonic patients a month, usually after they've spent 4 to 8 weeks in a hospital getting every test but an autopsy, and then somebody decides they need ECT and they get better. Every time I treat one of these individuals, I think about how many are dying in nursing homes or sent off to nursing homes or rehab places without effective treatment because of the lack of availability of ECT and the lack of knowledge about this condition. So the holy grail now for electrical stimulation of the brain is, can we find a way to use electrical stimulation that has a therapeutic effect that does not cause a grand mal seizure and all the potential side effects of a grand mal seizure. Transcranial magnetic stimulation for depression is very promising. It's now approved by the FDA. The idea is that we use magnetic energy to cause depolarization in the neurons, and that depolarization of the neurons increases depressed areas of the brain and has an antidepressant effect. Typically, I think this slide is a little better, we're stimulating the dorsal lateral prefrontal cortex, basically right here, and that cortex is interconnected through central nervous system pathways to the limbic structures, and that plays a role in mood modulation and depression. So the effect is not just an immediate effect of where we stimulate the brain, which is in the dorsolateral area, but goes back into the associated areas, including the limbic system. And that this system is involved in mood, motivation, and arousal. So there's electrical energy in an insulated coil on the scalp. The patient is awake when this happens. There's a sensation of tapping. Sometimes it's significant and people find it disconcerting. It's a pulse magnetic field. There's a noise associated with the field itself. There's a clicking sound, so people cover their ears when they're getting the treatment. The treatment passes unimpeded through the cranium for about 2 to 3 centimeters. And one of the issues now is enough of the brain getting stimulated, because it's hard to induce a focal magnetic field through flesh and bone into the brain without too much heat that we can't develop the machines that we need to do it. So it induces a focal electrical current in the brain, and that you get both a local effect and a distal effect because of the brain circuitry. And it's delivered as single pulses or repeated trains of pulses. So what we need is an algorithm. We need to be able to identify people who benefit from these treatments, are likely to respond to them. We need to train people better. We're constantly battling a public stigma about using electrical energy and particularly ECT that goes back for 60 years of prejudice. How we define both treatment resistance needs to have a general agreement. Most of us define it as 4 failed antidepressant trials at adequate doses, adequate periods of time. It's often hard to establish that in the patient population. If we've done that, the ECT remission rate is roughly 75 to 85%. The ketamine response/remission rate is roughly 40 to 50%. Dr. Sanacora will talk more about ketamine infusion therapy and what we're finding with that in a few minutes. So it's a rate about roughly half the rate of ECT, but much easier to administer in some ways. The transcranial magnetic stimulation, despite all the hype, the best data for remission for major depression is about 23%. So you can just see how the percentages drop as we move to these treatments. The hope is we will learn more about electrical stimulation and be able to create a form of TMS that can have better efficacy in depression, not induce a seizure, and possibly also work in other conditions like chronic auditory hallucinations or OCD. I'm a firm believer that the algorithm should be patient-driven. The choice is important. I don't know if I told our chairman this, but I was talking to John Crystal about ketamine versus ECT, and he said who would possibly opt for ECT if they could do ketamine first, and I had just done 2 consultations on 2 individuals who didn't want ketamine because they wanted a proven treatment like ECT because they wanted to get better and they didn't want to monkey around with something new. So I think patient choice is important and it should drive our decision making. I'm getting stared at, right? I think I'll stop there and answer questions. Do I have time? Okay.
Would ECT be considered safer for treatment of severe psychiatric illness with pregnant women versus medication in the cases where the pregnant woman actually does need some help?
Well, the short answer is yes. Oh, I'm sorry. The question was, is ECT safer than medication during pregnancy in a depressed pregnant woman? Is that?
Yes, thank you.
So long answer, I have a healthy respect for the fact that 1% of pregnancies end up with some kind of birth deformity, so I am very careful about who I would treat with medication or ECT during pregnancy. I think there's some very clear indications for needing one or the other, such as weight loss, loss of functions. Obviously, suicidality is worth the risk. I think we're a little glib about how safe medications are. If you go back to some of the side effects like weight loss, fatigue, those are not great things in pregnant women. We just don't know. ECT has been used successfully for 30 years. We've published several series of using it in pregnancy. It requires special safety conditions because of the changes in heart rate during the delivery of the treatment that can sometimes cause premature contractions and early delivery. We've never seen that, but we typically, after 25 weeks, do the patients who are pregnant in the OBGYN suite in case they need to be delivered. Fortunately, we've never seen that. But I think there's a careful risk-benefit that you have to consider around pregnancy that would be a much longer discussion. Fortunately, the maternal and fetal medicine people have been very good about consulting with us and discussing these cases and making decisions about what the safest treatment is. But I think it should be a very careful decision. I think I was trying to point to this gentleman and I missed him. I'm sorry, sir.
No problem. What about combining
You would think so. Unfortunately, some of the things that seem rational and rationally driven don't always pan out. So far, nobody's been able to demonstrate, I'm sorry, I should have repeated the question, using ketamine and ECT together to have a combined effect. We've used ketamine with ECT frequently for other reasons because they can affect the nature of the convulsion. There's also some data that it may reduce cognitive, ketamine may actually have a neuroprotective effect when we use it in ECT setting. No one's been able to demonstrate increased efficacy or increased rate of response when they've combined ECT and ketamine. I think there hasn't been a large enough study yet, but I think we just don't know. We've been using ketamine in our ECT suite for more than 10 years. I think we actually reported a case of using ketamine in an individual for another reason who ended up not having a seizure but had a dramatic antidepressant effect. So I think we wrote something 10 years ago about maybe ketamine would help in depression. But we haven't, the combined use, there just hasn't been enough data yet to really know. And so far it's been negative. Yes, sir.
Yes, you mentioned the STAR study that as people do more and more medication, the probability of the treatment working gets lower and lower. I think it's 7 or 8%. Now, so a patient goes, does the medication, and talk therapy, it doesn't work, so we go to ECT, and now you're saying ECT has a 70 to 80% rate, which is fantastic. What happens to the 20% where it doesn't succeed? Do they go further depression?
So the question is what happens to people who don't respond to ECT after they failed multiple medication interventions? Now they're in the 20% group that doesn't get better with ECT. What do we do? One of the things that I have a couple answers to that. One of the things I'm proud of in the interventional psychiatry service is that we have our equivalent of a tumor board where we meet once a month and talk about complicated cases and what we might do and try to come up with a strategy for treating people. I've never seen someone who's exhausted every possible medication or medication combination. So I think there are always options, and we try to look at people like that, whether they're classes of medications they haven't tried that might be promising, other combinations. Right now we've had people who have failed ECT and then responded to ketamine, but we've also had people who failed ketamine and responded to ECT, so we still are trying to figure out that algorithm. But my take home about that is there's no way that every possible medication was exhausted. It should get reviewed carefully, looked at, and other strategies developed. And we see patients who've been on 8 different medications, but there are 40 other options. So I think there's always something else that can be done, and I wouldn't give up on anybody. Yes, ma'am.
The biggest thing I've heard is memory loss. Have there been any studies or can you speak to non-debilitating memory loss that people have had with ECT?
The question is, what is the memory loss associated with ECT? When you induce a grand mal seizure, you typically lose an hour of memory before the treatment and an hour of memory after the treatment, which is very common. It's not invariable, but it's very common. And I tell people that they may forget the conversation they had with their wife on the ride into the hospital before the ECT, and they'll wake up after the ECT treatment, and the last thing they remember is getting up that morning, and they don't remember that hour or so. Some patients tell me they don't remember things their wife tells them anyway, or their wife tells me that to begin with. The issue is, for me, is what we call autobiographical memory loss, which is forgetting significant events. I tell all our patients that it's possible to have isolated autobiographical memory loss, that you'll forget you went to a party or your cousin's wedding 4 months before you had this treatment, and that may or may not be due to the ECT treatments. I've never seen anybody with global memory loss, and for me, I tell the story of a famous writer we treated who started writing again and went on 60 Minutes, and they interviewed him, and he talked about how he'd gotten back to writing again, and it had restored his ability to be an artist. And then they interviewed the person who was opposed to ECT. And she said that she's totally forgotten everything that happened in her life before the ECT treatment, and that she was sitting in her room in the hospital before she underwent her first treatment, and the psychiatrist came in and told her, don't worry, you won't have any side effects at all. There are no side effects associated with this treatment. So I'm watching this and I'm thinking, am I the only person in America who wonders how she remembers a conversation with the psychiatrist, but she's forgotten everything else? So memory's complicated. I do think you have to take it seriously. I do think people can have isolated memory loss, but we're also treating people with very significant illness who've been depressed for a long time. Depression affects your concentration, your enjoyment, your energy, your recall, ability to learn new tasks. If you measure memory functioning, that improves as the mood improves with ECT. But I think you put those together along with changing meds 8 or 10 times over the 6 months before you had ECT, it's not uncommon to have memory problems. Whether it's all due to the ECT or not, I think the jury is still out.
We're going to need to move on.
Okay.
Time. Thank you very much.
Sure.